Dr. Saama Sabeti for joining us today. She's out on the West Coast, and we're lucky to have her talk today about fungal keratitis. But for those of you, I'm sure many people who are listening know who she is, but those who don't, Saama has just finished her fellowship in cornea fellowship at the University of Montreal. She did her residency in Ottawa, the University of Ottawa. And so she will be coming back and joining us at Precision Cornea Center, which we're super pumped about. And so the team is all awaiting your arrival, Saama. I've been saying how you're a big meanie and they should be really prepared to not look you directly in the eyes and to follow your commands. But once they know you, they'll see how much of a sweet person you are. We're so fortunate to have you. And I was telling the team that when I first met Saama, when she was a resident, I knew right away she had something really special going on. And so I'm so fortunate to have her part of our team. So Saama, thanks so much for taking the time out of your off time to help us understand fungal keratitis better.
Thank you so much, Kashif. It's honestly a privilege to be able to join your team. I am incredibly excited to be coming to Precision in a few weeks. You've been an incredible mentor to me for years throughout my residency, and it's really a dream to think that I'm going to be coming to work alongside you and continue to learn from your expertise. So thank you very much, and thanks for having me here today. So the topic of our rounds today is fungal keratitis, and the goal is to basically provide an overview for residents, fellows, general ophthalmologists, cornea specialists, and anyone else who's interested on the topic of approaching diagnosis and management of fungal keratitis. And this will include as well a review of the results of the Mycotic Ulcer Treatment Trial 1 and 2, which some of you may have heard of. So I have no conflicts of interest or financial disclosures. So the objectives of the talk are to address the significance of and risk factors for fungal keratitis, to conduct a brief review of basic mycology, to review the clinical presentation, diagnostic approach, medical and surgical management of fungal keratitis, and this will include reviewing the outcomes of the MUT 1 and 2 trials. So we'll get our feet wet with a clinical case. This is a case that presented during my fellowship in Montreal at the CHUM. And I'll introduce to you briefly this patient, and we'll sort of interject his progression as the talk moves forward. So this is a 63-year-old gentleman who presented with redness and severe pain in the right eye. He discloses a history of trauma by a branch to the eye 3 weeks prior, and he actually had found out the name of the species of the plant and brought it to us. So it is the Siberian pea brush. Before seeing us, he had already seen an optometrist and an ophthalmologist in the community, and so he had been started on treatment. So since 10 days before seeing us, he was already on Vigamox hourly, amphotericin B hourly, Pred Forte twice a day, and Cyclogel. Till date, the cultures had been inconclusive, and so this was really essentially empirical treatment that was started for him until a diagnosis could be reached. And at this point, he had presented to the cornea clinic at a tertiary care hospital where we were. So we'll get back to that case in a bit. I wanted to provide a brief overview of why this topic is so important. Infectious keratitis is a leading cause of monocular vision loss worldwide, with at least 2 million new cases occurring per year globally. And fungi account for 5 to 10% of those cases of infectious keratitis overall, with higher rates reported at up to 44% in tropical and subtropical regions due to the hot and humid climates there. Early diagnosis and treatment is crucial, as fungal keratitis carries high ocular morbidity. Fungal organisms are more likely to perforate the cornea than bacteria. And in terms of the male to female ratio, it's found to be 2.5 to 1, which likely reflects the higher prevalence of male involvement in agricultural and outdoor work. So it's important to know the main risk factors for fungal infection because these should be red flags that should alert you to think about the possibility of a fungal infection and questions for you to specifically ask on history. So the number one risk factor in developing countries and overall in the world, because the highest prevalence of fungal infections do occur in developing countries, is trauma with vegetable matter or soil contaminated objects. In contrast, in developed countries, contact lens wear has now been found to be the primary risk factor, up to 37% of cases in a major US study. So asking the patient about good contact lens hygiene and taking that full aspect of the history is very important. Ocular surface disease, essentially any issue with the epithelium. So if an individual has poor epithelial integrity, such as in the cases dry eyes, exposure keratopathy, recurrent HSV, PBK, etc., they can be at risk of developing a fungal infection. PKP, so a patient who's post-PKP, has a particularly increased risk due to denervation of the cornea, the presence of sutures, and the use of chronic steroids. And yeasts are more commonly isolated than molds in these cases, as is the case with suppressed immune function. So patients on topical or systemic steroids, or patients with other causes of immunosuppression, such as the use of immunomodulatory therapy, HIV, diabetes. Again, these patients are at higher risk for fungal invasion of the cornea. Other risks include chronic erosions or ulcers of other causes, chronic keratitis, and other corneal surgeries. So in terms of pathophysiology, I had alluded to a loss of integrity of the epithelial barrier, and this essentially can allow fungal organisms to invade the cornea, penetrate through the stroma, work their way deeper through the use of proteolytic enzymes and toxins, which essentially break down the tissue and cause tissue necrosis, as does the immune inflammatory response of the host that's mounted in reaction. And fungal organisms can penetrate deep into the stroma, and they can even enter the anterior chamber through an intact Descemet membrane without perforating. As you know, they can also cause scleritis and endophthalmitis. So I thought I'd just present briefly a review of mycology, so just the basic classification of fungi. So fungi can be divided into yeasts, filamentous fungi, which can be further subdivided into septate and non-septate, or dimorphic. Dimorphic essentially means that fungal organism can be found as either a yeast or a mold, depending on whether it's being assessed in the host or in the lab. The ones that are important for us to look at in terms of keratitis are highlighted in purple here. So the yeasts, such as Candida, for example, and the filamentous fungi or molds that are septate. So, for example, Aspergillus, Fusarium, Curvularia. Non-septate filamentous fungi, such as mucor, for example, you'll remember that the mucormycosis is a potentially life-threatening disease of the orbits and sinus. Mucor is not so much found in corneal infections as are the others. And dimorphic fungi as well. Histoplasma is the implicated organism in POHS, for example. But when we're talking about fungal keratitis, we're talking about either yeasts or septate filamentous fungi. Yeasts are unicellular, round or oval. They reproduce by budding. They can sometimes form pseudohyphae or hyphae, which is important for microbiologists to assess anatomy when looking at a smear under the microscope. And examples include Candida and Cryptococcus. Candida albicans requires special mention because it's the main cause of fungal keratitis in cooler northern climates. It forms pseudohyphae expressing proteases and phospholipases, which help promote tissue penetration. And on culture here, the sort of classic appearances are these dome-shaped creamy white colonies that grow often by 24 to 48 hours. On the other hand, filamentous fungi occur more commonly in warm, humid areas, and they consist of multicellular tubular hyphae that grow by branching. Examples that are prominent with regards to keratitis are Fusarium and Aspergillus. So in terms of clinical presentation, fungal keratitis initially presents in a less inflammatory way than bacterial keratitis. They might only have mild conjunctival injection or little to no redness. Symptoms usually do not present acutely, but they gradually build up over 5 to 10 days or several weeks. Hence, the often late presentation of fungal infections weeks after trauma to the eye. Often, as things progress, they do experience pain that is sometimes out of proportion to clinical findings. When looking at the cornea or at the anterior segment of the eye on exam, key red flags to look out for are a feathery or filamentous margin to an infiltrate. Often this is gray or white in color. Yeasts can be sometimes a bit more yellow. The infiltrate tends to be superficial, elevated, dry, almost plaque-like sometimes. The classic teaching about satellite infiltrates, that's important. If you see satellite or multifocal infiltrates, that should be an alarm bell, but please note that these are not necessarily that common, even in fungal infections. So the absence of satellite infiltrates does not mean that you should not be thinking fungal. Fungal organisms can infiltrate deep into the cornea, even in the setting of an intact epithelium. You may sometimes note an immune ring, an endothelial plaque, or a hypopion, which might not be sterile, as fungi can actually penetrate into the anterior chamber without perforation. So usually in bacterial keratitis, if we see a hypopion, it's usually sterile, but that's not so much the case in fungal infections, as fungal elements can actually be found within the hypopion. So back to our case, this gentleman who presented to our clinic. On exam, he was found to have a large central infiltrate with sort of these finger-like projections, which were a bit peculiar for any bacterial ulcer that we've seen. Perhaps some satellite lesions, a surrounding ring infiltrate, or perhaps an immune ring, a hyphema, and he had a pressure spike at 54. So we'll come back to him again after reviewing now diagnostic methods, because that's our next step. So I'll review the main methods that are important to be aware of in the diagnosis of fungal keratitis. First and foremost, corneal smear and culture. Microbial investigations should always be carried out if fungal keratitis is suspected. And the sample is obtained from corneal scrapings. And I say scrapings as opposed to swab because fungal organisms can invade deep into the corneal tissue, and so often they're not sitting at the surface. You may need to actually scrape down and get a bit of tissue to send for culture and smear using a surgical blade, like a number 15 blade or sterile spatula. If you were to just use a swab, you may not be able to get deep enough, but also the sort of goop that might be sitting on the cornea may just be necrotic host tissue, not actually containing fungal organisms. So that scraping is really important. And also, if the patient has their contact lenses or case or solution with them, or they can bring them in, that would also be a very helpful additional item to send to the lab. Sometimes the corneal scraping culture can be negative, but the culture from the contact lenses might reveal the organism. So stains that are commonly used for identifying fungi. So gram stain has a sensitivity above the range of 50 to 60%. You can identify fungal elements on a gram stain. Not all fungal elements stain positive necessarily, but they can be identified based on their morphology. And sometimes they might be hidden under other materials. So it's important to tell your microbiologist what you're looking for. And then the results of the gram stain can be confirmed with the potassium hydroxide wet mount. This is a rapid, inexpensive test with a high sensitivity and specificity, so very useful. Calcofluor, white, and Giemsa are also other common stains that are used for fungi. So again, make sure to tell your microbiologist you're looking for fungal elements so they keep an eye out for that. In terms of culture media, of course, as with any ulcer that you would take a sample from and send for culture, you'd send your standard plates that you're used to sending, for example, blood, chocolate, agar, savarota agar, and your broths for your anaerobes, your thioglycolate or your meat broth. But here I'm pointing out just the most relevant ones for identifying fungal organisms where you may find growth. So blood agar, savarota agar, and brain heart infusion agar can also be very useful if you have it. Do note that fungal organisms usually take quite a bit longer to grow on culture than do bacteria. Rates of growth have been found to be 83% within 72 hours and 97% within 1 week. And so that other 3% may take weeks to grow. So those plates should be kept in the lab for at least 4 weeks for observation for growth. And also remember that cultures are not 100% sensitive in the first place. So a negative culture does not rule out the presumed diagnosis. If you have a high suspicion, you really should be repeating a culture if the first one was negative. Again, either your yield might have been too little, your depth of scraping might not have been adequate, or it's just a fungal organism that takes a long time to grow and hasn't shown anything. Maybe giving it another chance with another scraping might yield better results. Next is confocal microscopy. So this is a very useful tool. Not all facilities have this, but if you have access to it, it can be very helpful. It provides optical sections through the full thickness of the cornea with a resolution as small as 1 micron. So you can directly identify the presence of fungal elements. You can see them. And so above we have an example of hyphae branching at 90 degrees. That's classic for fusarium, whereas aspergillus would show branching at 45 degrees, for example. And you can also see Candida pseudofilaments on the image there. Of course, it takes an experienced eye, but if you have this diagnostic tool available to you, I think that it would be very valuable. It has high sensitivity and specificity. It's non-invasive. And it can allow for early diagnosis while you're waiting maybe up to several weeks for a culture result. Corneal biopsy. So this isn't undertaken too often, but it is sometimes indicated. For example, if you perform a repeat culture and that second culture is also negative after 48 to 72 hours, and you really feel based on history and clinical exam that this is very suspicious for fungus, it would be worth your while to consider a corneal biopsy. The other indication is just a deep stromal infiltrate to begin with. So it's an infiltrate that you wouldn't be able to culture from the surface. And lastly, I'll mention PCR. This is a rapid test. It provides results within 4 to 8 hours. It's sensitive. Only a small clinical sample is needed. It has the highest positive detection rate when compared to gram stain and culture, but it can also have high false positives because even contaminant DNA can be amplified and read as a positive reading. So it is expensive. It's not widely available. Its main uses right now in most places are for research, but it's just something I thought should be mentioned. So going back to our clinical case, so the impression based on the history, the appearance, was that this is likely fungal keratitis, probably filamentous, and that the patient was in some form of pupillary block glaucoma. His pressure was 54, and in cases of fungal infection, you can have severe inflammation and development of membranes in the anterior chamber, so perhaps he had pupillary membranes that were causing block. So his IOP was treated medically. His cornea was scraped for smear and cultures. If you recall, he was on Pred Forte twice a day from an outside treating physician. So we stopped that because of the known risk to patients with fungal infections. It can make things much worse. He was already on Amphil B. So this is a case where a patient was empirically started on antifungals. And in this setting, we opted to add another agent. So we added voriconazole. At the time, natamycin was not readily available. You need to apply for special access, so that takes time. We also did start fluconazole orally in conjunction with an ID consult, so we got their help as well. And they helped us out with monitoring the liver enzymes every 2 weeks. we continued Vigomox and Cyclogil. So our gram stain came back with evidence of filamentous fungi. So the treatment was on the right path in terms of starting antifungals. Within the following week, he developed more pain. The ulcer rapidly increased in size. He eventually developed an almost complete epithelial defect of the entire cornea, extending beyond the ulcer margins. The B scan showed a choroidal effusion and a possible exudative retinal detachment. And then cultures came back with the following organism, Metarhizium anisopliae. This was the first time I'd heard of this. So upon reading a bit about it, it's a filamentous fungus. It's actually becoming more and more commonly used as a pesticide, a biological insecticide. It kills insects within a few days of infecting them. There's only been rare cases of infection in humans, but it has been reported, and keratitis is one of those infections. So on to treatment of fungal keratitis. So there are 4 major classes of antifungal agents to be aware of: the polyenes, the azoles, echinocandins, and pyrimidine analogs. Most of us have probably heard mainly of the polyenes and the azoles. Please note that only natamycin is FDA approved for use in ocular fungal infections. All of the other medications listed here are off-label for ophthalmic use, but they are used, as we will begin to discuss. So natamycin has been considered the standard of care for filamentous fungal keratitis, so fusarium, for example. And as I said, it's the only currently approved antifungal drug for ocular fungal infections. There have been no new drugs approved, I believe, since the 1960s for use in ocular fungal infections. Ampho-V is considered first line for treatment of Candida. And then newer azoles, including voriconazole, have been reported to have good in vitro activity against most fungal ulcer isolates. So a lot of research in recent years has gone into the use of azoles, specifically voriconazole, and we'll discuss why. So I'll delve into the Mycotic Ulcer Treatment Trial because it's relevant at this point. This is a trial that looked at the use of topical voriconazole in one subset and oral voriconazole in another. So we'll discuss the 2 trials separately, and this was for the treatment of filamentous fungal keratitis. So the results do not apply necessarily to yeast, just to keep that in mind. So I don't think I have an ability to do a survey or poll, but I just like everyone to think about which one of these 2 drugs would have been your first line treatment for filamentous fungal keratitis if a case walked in through the door. And in 2009, a survey was performed on corneal specialists all around the world, and most of them actually believe that the existing treatments that we have for fungal infections are only moderately effective, and that if it were available, voriconazole would actually be their preferred choice. So the sense that I'm using other agents, but if I could have gotten my hands on voriconazole, I would have used that as my agent for filamentous fungal keratitis. And this thought is, it's understandable where this comes from, because voriconazole provides a broad spectrum of antifungal coverage in vitro. One study by Walsh and colleagues in 2002 demonstrated that it was the only drug tested to which 100% of fungal isolates that are commonly implicated in keratitis were susceptible, and that included filamentous and non-filamentous fungi. So it showed promise. It was the new kid on the block that showed a lot of promise against fungal organisms in vitro. Also, it was shown in vivo to have excellent ocular penetration, whereas natamycin is known to have poorer penetration into the stroma. So the MUT1 trial was designed to answer this very question, whether topical voriconazole might be a better agent for combating fungal infections compared to natamycin. So their primary outcome measure was best corrected visual acuity at 3 months, and they had multiple secondary outcomes, but the main one to mention is the rate of corneal perforation and/or therapeutic PKP. This was a double-masked clinical randomized controlled trial. It took place in India. The eligibility criteria was smear-positive filamentous fungal ulcer patients with a visual acuity between 2040 and 2400. And the treatment regimen we'll discuss again later, but in general starts at Q1 hour and is gradually tapered over weeks, if not longer. Over 300 patients were enrolled. The most common fungal isolates were Fusarium followed by Aspergillus. And note that the median treatment duration in this study was approximately a month, just to get an idea of how long fungal infections do take to treat. So the main conclusions of this study were that natamycin provided better best-corrected visual acuity at 3 months, lower incidence of corneal perforation and or therapeutic PKP, shorter time to reepithelialization, lower rate of culture positivity at 6 days, and smaller scar size at 3 months. Note that some of these outcomes were attributed mainly to Fusarium, and remember Fusarium consisted of the majority of the sample. But when a subgroup analysis was performed, it was found that there was no difference in visual acuity at 3 weeks and 3 months when comparing just non-Fusarium species on natamycin versus voriconazole. So that was attributed to Fusarium, as was time to reepithelialization. But overall, for all species, there was a lower incidence of corneal perforation and or the need for a transplant. And there was a lower rate overall of culture positivity at 6 days for all species. So all in all, I think it was fair to draw the following conclusion that natamycin was associated with significantly better outcomes than voriconazole for filamentous fungal keratitis, with much of the difference, yes, attributed to improved results in Fusarium keratitis. And the overall recommendation that we can draw from this is that topical voriconazole should not be considered as an appropriate monotherapy for Fusarium. So that's sort of a clear learning point that came from this study, because natamycin clearly did do better. And so we'll move on to MUT2, where they looked at the oral agent, voriconazole versus placebo. So the thought was, we saw that natamycin was superior to voriconazole topically in MUT1, but perhaps this finding could be attributable to intermittent drug dosing of the topical medication, resulting in subtherapeutic drug levels. And so if the oral version was used, maybe that would help. It exhibits excellent ocular penetration, and perhaps it could provide more consistent drug levels, especially for deep-seated infections. So MUT2 was designed to investigate whether oral voriconazole would be a beneficial adjuvant to topical antifungal therapy. And so the primary outcome here was the rate of corneal perforation or the need for therapeutic PKP within 3 months. In these patients, actually, they had a lower starting visual acuity. So these are more severe ulcers. So visual acuity of less than or equal to 2400. There's a lot of info on this slide, but the main summary is that the groups were split into a treatment arm with PO voriconazole and a placebo arm, and all patients received topical antifungals. They first were on just voriconazole, but once the MUT1 trial results came out, the natamycin was added because it was clearly the superior drug. So again, in this cohort, Fusarium was the most common organism isolated, then Aspergillus, and lots of numbers in this table, but in general, the summary here is that with respect to perforations of the cornea and the need for therapeutic PKP, there was no significant difference in likelihood of either outcome using voriconazole versus placebo. So again, no difference between the groups in terms of perforation or need for PKP and the other outcomes, so visual acuity, time to epithelialization, etc. Whereas at the same time, voriconazole also induced a higher incidence of adverse effects such as liver enzyme increases and visual hallucinations. So the conclusion of MUT2 was that there seems to be no benefit to adding oral voriconazole to topical antifungal treatment in the treatment of severe filamentous fungal ulcers, and in light of the fact that it also causes increased risk of systemic adverse effects. So the risk-benefit ratio just doesn't seem to make sense with respect to oral voriconazole in the setting of severe filamentous fungal ulcers. So with that in mind, I'd like us to just carry that into our brief review of the various medications. So we have the first class, the polyenes. This can be split into natamycin. This consists of natamycin and ampho-B. Natamycin, again, is the only FDA-approved drug. It only comes in a topical, commercially available suspension, and it's first line for filamentous organisms. It can be an alternative to ampho-B for yeast. Amphotericin, in contrast, can come in other formulations. This is a medication that's compounded from the IV solution, so that's diluted in order to make these suspensions, and it can be used intrastromally, intracamerally, intravitreally. First line for yeast, and maybe an alternative to natamycin for filamentous, mainly aspergillus as opposed to fusarium. And these other adjuvant therapies, it's just useful to know about them. If you have a patient with deep keratitis that doesn't seem to be responding to topical therapy, maybe it's because of poor penetration to the deep layers. And so an injection can reach that area and offer higher sustained concentrations. And then I just wanted to point out here in terms of disadvantages of natamycin, it's mostly effective for superficial keratitis. It doesn't penetrate the corneal stroma very well, as we had discussed. So monotherapy is not effective for deep lesions, so an adjuvant should be considered. It can be expensive and it's not widely available in developing countries. My understanding is that here in Canada, we need to fill out a special access form, and it may be different from country to country. And amphotericin B, as we discussed, first line for Candida, active against aspergillus. It does penetrate the deep corneal stroma, but it requires an abraded, a non-intact epithelium to do so. So periodic epithelial debridement is recommended. We had discussed that it comes in other routes. It does require a compounding pharmacy. But in our case, for example, we were able to get amphotericin B faster than we could get natamycin, because what you need is just access to a compounding pharmacy, whereas for natamycin, it needs to be ordered in. Azoles, this slide is very busy and we don't need to go into details, but I just wanted to provide you with a brief view of the various types of azole medications, the various routes that are available. Voriconazole is available in the same ways that amphotericin B is, plus an oral formulation. Fluconazole can also be used as an injection as well. So usually azoles are used in the case where a patient is or the organism is resistant to a polyene, so resistant to natamycin or ampho-B, so adding this agent for additional coverage, or if a patient can't tolerate the other medications. And then the injection forms are essentially useful in cases of poor adherence, because it allows for longer local drug release, essentially. And the oral formulation is important. You need to monitor the liver enzymes every 2 weeks. So getting help from ID with that is an important point. And lastly, echinocandins and pyrimidine analogs. So these drugs are available as topical medications, and again are more for fungal keratitis that did not respond well to your first line polyenes. This is a nice flowchart that I found by Mueller and colleagues in Brazil, and they essentially split this sort of treatment pathway into filamentous versus yeasts. And so natamycin would be the first option, backup would be ampho-B or additional adjuvant, whereas the opposite is true for yeasts. In some papers, actually, an azole might be recommended as a second option as opposed to natamycin. And then you can see, based on whether you have intraocular involvement or just a deep keratitis needing deeper, like an injection of medications, or AC involvement, you could cater your adjuvant therapy accordingly. And in the end, if treatment is not working, then consider changing within the same class. So I just thought that's a helpful way to look at it. You have a lot of tools in your armamentarium. So in summary, to select an antifungal agent, as soon as you have a gram stain results, you can start catering your treatment. So if the microbiologist sees hyphae, that's indicative of filamentous fungus, you can start topical natamycin. Yeast or pseudohyphae, the go-to is topical Ampho-B. Voriconazole drops, as we learned in MOT 1, is not appropriate for monotherapy for fusarium. If it's a combination of filamentous and yeast-like species, you can combine natamycin and Ampho-B or an azole. And if there are deep stromal lesions, consider adjuvant therapy, so intrastromal injections or systemic therapy. Again, topical azoles play a role as an alternative or as an adjuvant. Oral azoles can be an adjuvant for deep-seated infections, and co-management with the ID team is extremely important, because once patients start developing symptoms on these medications and their liver enzymes go up, you need help from an internist in terms of deciding how to change the medications. So other key management considerations. So antifungal dosing, we would start with every hour for the first week and then gradually taper once a response is observed. So once the epithelium is closed or the infiltrate starts improving slightly, advise a patient to discontinue contact lens wear, do not patch, continue the antibiotic for protection and the cyclogel or a midriatic to attempt to prevent pupil block. Do not give topical steroids. So this is a key point. It can potentiate infection and increase healing time, decreases the chances of success of your antifungal therapy, and you have a much higher risk of recurrence of infection post-PKP if the patient had used steroids prior to their PKP. And another recommendation that we find in the literature is frequent debridement. So again, getting rid of necrotic tissue, but also helping decrease some of the organism load and enhancing penetration of antifungal drops. Daily follow-up, just like any other ulcer, until you start feeling comfortable that there is a significant improvement. Remember that antifungal therapy can take weeks, so on average 4 to 6 weeks. If it's a deep-seated infection, sometimes this takes several months to eradicate. And remember that drug toxicity can make the cornea look worse. And so it can be a bit hard to assess, but just regular routine follow-up and attention to changes in the infiltrate are key. Back to our case briefly. So we discussed with ID, and based on the literature review on metarhizium, we came to understand that it's not sensitive to amphotericin B, so we stopped that. It is sensitive to caspofungin, so we started that. We were able to add natamycin once it was approved, as this is a filamentous fungus, and we continued voriconazole as an adjuvant topical medication. We did also continue oral medications, but ID had to keep changing based on liver function tests and patient symptoms. Lastly, I'd like to delve just briefly into surgical management, just to cover the options that have been described. So for small superficial ulcers, we talked about debridement. Also, a paper published by you and colleagues in 2015 described a technique in which a lamellar keratectomy was performed that incorporated the infiltrate. So basically debulking the infiltrate, removing that, and then injecting deep to that intrastromal fluconazole. So that's an option that has been described with success. And for deeper or more extensive ulcers, cross-linking has been described. There has been very variable evidence in terms of whether it works or does not work, but in general, it seems to lack strong evidence for being effective in eradicating fungal organisms. PKP, and I'll talk about indications. And then lastly, evisceration or enucleation in advanced or ruptured cases with no visual potential. Indications for a PKP. So if a patient has an impending perforation, a perforation greater than 2 millimeters, or a perforation that's smaller than 2 millimeters but has been temporized with glue and patch and is basically on its way to a transplant, if you can see that the infiltrate seems to be extending or advancing towards the limbus, you know, we always hesitate to do a transplant on a hot eye. You want the eye to be calm and ideally free of infection before doing a transplant, just for the optical reasons, to get rid of a scar. But if you see that an infiltrate is advancing towards a limbus, one has to think about, okay, well, if I'm stuck at that point and I have to do a transplant once this infiltrate has reached the limbus, that's not good for the outcome of the transplant in terms of rejection and failure. And having to end up with a large diameter graft is also not good in terms of increasing risk of rejection and failure as well. So those are things to consider before things get so bad that it becomes even harder to manage the consequences down the road, and failure of medical therapy, which essentially includes all of the above. So surgical considerations during PKP in these cases: after removing any membranes or material from the anterior chamber, consider a large sectoral iridectomy, especially if you're using a large diameter graft. Remember, these are patients that are not on steroids, and we prefer for them not to be on steroids post-op, so they'll have likely a lot of inflammation post-op, and we don't want them to develop pressure issues due to synechiae formation. With respect to the lens, if possible, it's preferable to leave it undisturbed to prevent spread of the infection to the posterior segment, unless it's already exposed and involved in the infection. If so, then an extra caps extraction would be merited, and then you'd leave the patient aphakic. It's recommended to perform an anterior and posterior chamber wash with antifungal agents, and then start the patient on systemic antifungals post-op if they're not already on those medications. And again, like in terms of post-operative care, I'd mentioned try to avoid steroids until 2 to 3 weeks post-op. One paper actually discussed consideration of cryopreserved tissue, which I thought was an interesting idea, essentially doing a tectonic PKP where you're not worried about future rejection because you don't have viable cells in that donor tissue, so you won't need to use steroids, and then wait until the eye is quieted down and then perform a transplant with fresh tissue. And in terms of continuing antifungals, don't just stop the day of surgery. You, of course, continue in case there's any residual organisms in the host. And if fungus is present on the pathology report in terms of host margins of your donor cornea, then consider extending for 6 to 8 weeks. One consideration is using cyclosporin 1% instead of topical steroids. So it has both anti-immune and antifungal properties. So the last little bit with respect to our clinical case, sadly, despite all the medications he was on, he continued to worsen. He developed vitritis on V-scan. So the plan with retina was to perform vitrectomy and a corneal graft. So it required a temporary K-Pro for view, vitrectomy, and then a PKP. Before he went to the OR, we did basically as a Hail Mary try cross-linking to just try to perhaps decrease some of the load of fungal organisms. And we injected subcon voriconazole for that effect as well. And post-op, we continued his antifungals and basically tapered off after a month or so. He was very inflamed, as you can see even in this picture here. Just the periphery of the cornea did not look good. He had severe melt. He had contraction of the graft-host junction, loose sutures. So we felt he did need some sprinkling of steroids there, even though we would not have necessarily wanted to use steroids in the setting of fungal keratitis, but we added cyclosporin and ramped it up to Q2H and added doxy as well to try to help with the inflammation. Unfortunately, in the end, this patient had a poor outcome. He developed hypotony with membranes that even affected the ciliary body. The ciliary body became atrophic. And so at this point, his eye is hypotenuse. It's essentially thicical, and he's got severe pain, so he's considering evisceration. So in conclusion, as we can see, fungal keratitis can have devastating consequences. You need to have in the back of your mind a high degree of suspicion based on the history and exam in order to catch the diagnosis and start treatment early. Again, brief highlights: Amphil B would be our first go-to for yeast, natamycin, the first go-to for filamentous fungi, And from one, we see that voriconazole drops are not effective as monotherapy for filamentous fungi. And lastly, remember to ask for help from your ID colleagues. They may help you with choosing the medication based on the sensitivity of that organism and their knowledge of it. And of course, for monitoring for side effects and liver toxicity. So thank you very much. And I'm happy to take any questions if there are any.
Wow, that's great. Thanks, Saama. That's a nice overview of kind of all aspects to kind of think about when it comes to fungal keratitis. We do have one question. The question is that, often without the anti-VEGF effect of steroids, these ulcers can lead to very severe neovascularization, which limits then the future success of optical grafts. Any thoughts on how to mitigate or deal with that?
That's an excellent question. Again, I mean, I'd mentioned perhaps thinking of the use of other options. So cyclosporin is an anti-inflammatory medication. And we're not talking restasis concentration, but 1%. So a strong concentration of it perhaps might help, might be preferable to augmenting the dose of steroids. Using doxycycline. Of course, if you're, the worry about that is in the end, which outcome carries the higher risk, the possible perpetuation and enlargement of a fungal ulcer in the setting of steroids versus having to deal with, yes, the very real potential outcome of having neovascularization and the potential negative prognosis for a graft because of that. But I think each case, I think it would be answered on a case-by-case basis, sort of judging how far the patient has come along, how much improvement they've had, I think, before considering to start steroids. That's a tough question, honestly, for I was thinking about this case as well because we did have him on steroids post-op because he was melting, and you need to balance out the risk and benefit. I mean, if a patient melts and then perforates again on a brand new graft, you've got other issues to deal with. So that's an excellent question, and it's not an easy one to answer, but I think that the clinician can potentially use their judgment based on each case and how things are either improving or worsening in terms of introducing steroids. What are your thoughts on that, Kashav?
So yeah, I agree. It's like sometimes you're like, you look at the eye, you feel like I want to give steroids. I think this eye needs steroids, but then you think about what you mentioned, after transplant, what the prognosis is, what happens at the time, what's melting. So it's a tough call. Some people have advocated the use of PO by mouth steroids. Some have said topical, different things. Another comment from Darrell Lewis is, as part of his Hail Mary attempt, there may be some science behind using hyperbaric oxygen therapy, especially for fungal scleritis cases.
Yes, I've read about that too. I haven't found too much evidence, but there are studies pointing in that direction that might be, again, a Hail Mary. Basically, it may be worth the attempt if you have access to that, to hyperbaric chamber.
So the other thing with cross-linking is we've tried a few cross-linkings, maybe half a dozen cases in patients, and we found that it may work perhaps well in bacterial cases, but with fungal cases, it was just not, we didn't find it very helpful. Again, the N was small, but cross-linking, there was some thought at one point, maybe 8-9 years ago, that perhaps a cross-linking creates a barrier through which deeper penetration of medications may not be possible for the posterior cornea, but that was proven not to be the case. So that's still kind of a big question mark. And so, these are tough cases. The Hail Marys sometimes have to be factored in. I often tell patients that they'll probably need a few transplants. We've done some scleral keratoplasties where scleral has been involved. And so that's been difficult surgery, but often these grafts, because they go from beyond the limbus to the sclera, it's not easy to kind of replace it. So you end up doing other grafts within that graft, sometimes doing an EK to help the grafts out if they're having some endothelial dysfunction. These are messy cases for sure.
Yes. Yes.
I had a question for you. What have you tried, or have the people in Montreal used sutures to get cultures done for deep infiltrates or deep infections, where the superficial area is pretty okay, but to get access to the deeper tissue, the deeper infection involvement?
Yes, so you're referring to the passing of a silk suture, for example, from clear cornea through the infiltrate beneath and out, and sending that off to the lab for microbiological assessment. I had not seen that done during my fellowship, but that is also an excellent thought to have in your mind, basically when you've reached the point where you're deciding on doing a corneal biopsy or not. So I think at that stage it may be worth trying and seeing, but if you have access to an OR and it's not, the lesion is not in the visual axis, I feel that corneal biopsy, because you're sending it to microbi and histopathology, may give you more fruitful results. But I wonder if that passing a suture might be helpful in those cases where you don't want to do a biopsy through the visual axis. That's a really good point you brought up there, the suture. Thank you.
So we have Dr. Baptiste Algoudi. He's our fellow, our junior fellow. And I'm going to put him on the spot because he's from India, and obviously they see a lot more of these fungal keratitis cases than we do. I'm going to put him on the spot by having him share perhaps his experiences or his thoughts on what has worked or what has not worked in going through as a cornea specialist in India.
Yes, so looking at the scenario in India, it's mostly filamentous fungi, and we have a different distribution across, like for example, in the southern part of the country, it's more of Fusarium, and as you go towards the north, it's more of Aspergillus. And we also have a lot of pigmentary demataceous fungi which are very resistant to treatment. And as far as the treatment with the topical medications go, we follow what Dr. Sabeti just discussed, as in natamycin as a first choice, and then adding up either amphotericin or topical voriconazole as the second line. But most patients, we usually start them off with not just a monotherapy, but natamycin with an ampho or with a voriconazole to start with. And the other thing that in the last few years that we have been doing is going for an early intrastomal injection, because that kind of helps prevent the infection going further behind. And these deep stomal infections, and in a setting like in our country where repeat SKs are not possible to just have the drug penetrate further, we go ahead along with the topical medication in a week or 2 weeks. If it doesn't improve any further, we go in for intrastomal injections earlier. And the other thing that seems to work is kind of, there are these amphotericin and natamycin coated small tablet-like substances that come in that are like 20 to 30 microns in thickness. They are like a depot preparation that is used. So what we do is, like, around the area where the stomal infection is, the deep stomal infection is, just make a small lamellar dissection there and place that small tablet there inside and suture it. So that acts like a depot release of the ampho or the natamycin. And so these are some things that have had better results, because rather than just going topical, which is the best for the superficial fungal keratitis, the deep stomal ones and those which are close to the decimates, people just keep doing the topical ones and keep waiting, and suddenly they present back with end off and the eye is lost. So we go in for early intrastomal injections, early intrastomal depot preparations, intracameral ones, and so these have been like, and even to a large extent, what we usually do is subconjunctival injection of either voriconazole or ampho. Though we stain the conjunctiva there like yellowish green for a long time, but they, because patients they don't usually comply very well with early drops for a long time. So after the first or second week, if they don't do so well, we do an intrastromal plus do a peri-ulcer area, we do a subconjunctival injection as well. So it's like going as aggressive as possible in cases which don't seem to have an early response, which is that, how much we expect. So, but despite all of that, as she said, several patients lose the eye. And we don't wait really long if they have a very deep stromal infection. We go in for an early therapeutic graft so that we at least can save whatever is there. And we may have to do repeat transplants, but we at least know that we are doing something for the immediate betterment.
Okay, thank you. So on October 22, we're going to be having a business meeting for our Cornea Society. And one of the items that was raised by Dr. Slomovic in Toronto was, let's get some efforts together to get natamycin more readily available so we don't have to necessarily go through the SAP process for access. So that's one thing we're going to be discussing in a few weeks' time, because it is a big thing, because natamycin from various trials has shown to be quite effective, but yet it's hard to get access to quickly. And so hopefully we can make a change in that.
That would be great.
Awesome. Any other questions from the attendees? All right. Well, Saama, thank you again very much. It's 6 o'clock. It's been a great presentation and great discussion. Appreciate you spending time to kind of share your thoughts with fungal keratitis. I actually learned a few things. I wasn't so stringent on the ID follow-up, so I think it wasn't definitely every 2 weeks. So I think I'll have to kind of revisit what I do there. But thanks for the presentation, and we hope to see you very shortly.
Of course, thank you for having me, and I look forward to seeing you soon.
Okay, thanks. Bye-bye.
Have a great evening. Bye.